Bismillah ar-Rahman ar-Rahim. أعزائي الطلاب, today we talk about a new subject which is the malaria. The learning objectives include the pathogenesis and life cycle, the effects on red blood cells, clinical features, complications, investigations, and lastly the management and prevention. Malaria is a protozoan disease transmitted by the bite of infected anopheline mosquito. Human malaria is caused by Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malaria. Malaria is predominantly a disease of hot climates. However, it may occur in other parts of the world, such as Europe. Less frequent modes of transmission include blood transmission or injection and transplacental infection. The pathogenesis and life cycle. Almost all deaths are caused by falciparum malaria. Human infection begins when a female anopheline mosquito inoculates plasmodial sporozoites from its salivary gland during a blood meal, which carried rapidly via the blood to the liver, invading hepatic cells and begin a period of asexual reproduction. Now, this is a process producing what is called a pre-erythrocytic or schizogony, in which a single sporozoite eventually produce about 10,000 to 30,000 daughter Merozoites. At this stage, symptomatic infection begins. In Plasmodium vivax and ovale infection, a proportion of the intrahepatic form do not divide immediately but remain dormant for months to years before reproduction begins. These dormant forms, or what's called the hypnozoites, are the cause of the relapse that characterize infection with these two species. Merozoites invade erythrocytes and become trovozoites. Attachment is mediated via a specific erythrocyte surface receptor. In the case of Plasmodium vivax, this receptor is related to the Duffy blood group antigen. Most West African and people that carry the Duffy negative phenotype are therefore resistant to Plasmodium vivax malaria. This stage of development appears as a small ring form intraerythrocytic under the light microscopy. By the end of the 48 hours intraerythrocytic life cycle, which is 72 hours regarding the Plasmodium malaria, the parasite grown to occupy most of the red blood cells. Multiple nuclear division take place, producing what is called the merogony, and the red cell rupture to release about 3 to 30 daughter Merozoites. Each of these Merozoites capable of invading a new red cell and repeating the same cycle. Some of the parasites develop into a morphologically distinct, long-lived sexual forms, which is called the gametocytes, that can transmit the malaria. Malaria is always accompanied by hemolysis, and in a severe or prolonged attack, anemia may be profound. The causes of anemia in malaria may be due to hemolysis of infected red blood cells, hemolysis of uninfected red blood cells, dyserythropoiesis, splenomegaly causing erythrocyte sequestration, and depletion of the folate stores. Hemolysis is most severe with Plasmodium falciparum, which invades red cells of all ages, but especially young cells. Plasmodium vivax and ovale invade reticulocytes, while Plasmodium malaria invade normoblasts, so that infections remain lighter. Sequestration of red cells containing mature parasite in Plasmodium falciparum occur, which interfere with the microcirculation in the vital organs, which defends the parasite and act as a consequence. Only the younger ring form of the parasite are seen in the peripheral blood in falciparum malaria. In the other three or benign malarias, sequestration does not occur, and all stages of the parasite's development are evident on the peripheral blood smear. Plasmodium falciparum does not grow well in red cells that contain the hemoglobin F, C, or especially S. Hemoglobin S heterozygotes are protected against the lethal complications of malaria, which might be related to the low oxygen tension. The first symptoms of malaria are nonspecific: the lack of a sense of well-being, headache, fatigue, abdominal discomfort, and muscle ache, followed by fever. Headache may be severe in malaria, however, there is no neck stiffness or photophobia as that seen in meningitis. Nausea, vomiting, and orthostatic hypotension are common. The classical malaria paroxysms, in which fever occur at regular intervals, suggest infection with Plasmodium vivax or Plasmodium ovale. Fever starts with a rigor. The patient feels cold and the temperature rises to about 40 centigrade after half an hour to an hour. The hot or flush phase begins. It lasts several hours and gives way to profuse perspiration and a gradual fall in the temperature. The cycle is repeated 48 hours later. Gradually, the spleen and liver enlarge and become tender. Anemia develops slowly. Relapses are common 2 years after leaving the endemic area. Plasmodium malaria infection fever occur in bouts every third day. Parasitemia may persist for many years with or without symptoms. Plasmodium malaria causes glomerulonephritis and nephritic syndrome in children. Plasmodium falciparum infection, more dangerous than the other form of malaria. The onset is often insidious with malaise, headache, and cough. Cough and mild diarrhea are common. Fever has no particular pattern. Jaundice is common due to hemolysis and hepatic dysfunction. The liver and spleen enlarge and become tender. Anemia develops rapidly. Splenectomy increases the risk of severe malaria. The complications of malaria due to Plasmodium falciparum, including, first of all, severe anemia. Second, organ damage due to anoxia, such as coma and confusion due to brain damage. Oliguria, uremia due to acute tubular necrosis due to kidney anoxia and damage. Cough and even pulmonary edema due to lung damage. Diarrhea and congestion due to intestinal anoxia and damage. Jaundice and even encephalopathy, which is rare due to liver anoxia and damage. We have what's called the intravascular hemolysis or black water fever. This is associated with chronic falciparum malaria, most commonly in those who take antimalarial treatment irregularly or are deficient in G6PD. Hemolysis is unpredictable and severe, destroying uninfected as well as infected red blood cells. The urine is dark or black. Another complications of Plasmodium falciparum is hypoglycemia, especially in those who receive quinine treatment. Another complication, shock secondary to septicemia or hypotensive shock, metabolic acidosis, splenic rupture, or complication during pregnancy, such as maternal death, abortion, stillbirth, or low birth weight. We have what is called the tropical splenomegaly syndrome, or hyperreactive malarial splenomegaly. The definition of these terms: in some hyperendemic areas, gross splenomegaly is associated with an exaggerated immune response to malaria and is seen more common in adult. The condition is more common in female and in certain racial and family groups and is characterized by overproduction of IgM. IgM aggregates are phagocytosed by the reticuloendothelial cells in the spleen and liver. Light microscopy of the liver usually shows sinusoidal lymphocytosis. Anemia and lymphocytosis can be confused with leukemia. Portal hypertension may develop. Regarding the investigation, malaria should be considered if a febrile patient is in or has recently left a malaria locality. Thick and thin blood film should be repeated if necessary. In Plasmodium falciparum, only ring forms are normally seen in the early stages. Gametocytes may persist despite treatment and are harmless. Immunochromatographic dipstick tests for Plasmodium falciparum antigen are non-microscopic means of diagnosis. They should be used in parallel with a blood film examination. Differential diagnosis: other causes of fever with splenomegaly in the tropics should be considered, such as TB, visceral leishmaniasis, schistosomiasis, chronic brucellosis, in addition to leukemia and lymphoma. The management for all infections with Plasmodium vivax, ovale, and malaria, the drug of choice is chloroquine, 600 mg base, followed by 300 mg base in 6 hours. Then 150 mg base twice daily for 2 more days. Plasmodium falciparum is now resistant to chloroquine and so not used to treat this type of malaria except in area of chloroquine sensitivity. Quinine dihydrochloride or sulfate, 600 mg 8 hourly until the blood is free of parasite. Usually this takes 3 to 5 days. Then followed by a single dose of sulfadoxine with pyrimethamine, which is constitute 3 tablets of Fansidar. In pregnancy, a 7-day course of quinine should be given. Alternative to quinine plus Fansidar, we have another medication or alternative is mifloquine. In complicated Plasmodium falciparum, quinine is given as an intravenous infusion over 4 hours. That means 10 mg per kg up to 700 mg, repeated 8 to 12 hourly until the patient can take the drug orally. Intramuscular quinine may cause necrosis of the muscle, so it should not be used intramuscularly. In comatose patient, lumbar puncture may be indicated to exclude coexisting bacterial meningitis. Severe anemia requires transfusion, and careful attention to fluid balance is essential. Oliguria can be treated by furosemide or infusion of manitol. Exchange transfusion is life-saving in complicated, very heavy infection, and we mean by very heavy, more than 10% of red cells are infected. Hypoglycemia and septicemia should be treated. Dialysis may be needed if renal failure is developed. The prevention: clinical attacks of malaria may be preventable by drugs such as proguanil, which attack the pre-erythrocytic form, or by drugs such as chloroquine or mifloquine after it has entered the erythrocyte. Chemotherapy is begun 1 week before entering the malaria's area and is continued until 4 weeks after leaving it. Chloroquine over 5 years may cause serious irreversible retinopathy. Proguanil and chloroquine is safe during pregnancy. Mifloquine is contraindicated in the first trimester of a pregnancy. Fansidar should not be used for chemoprophylaxis, as it may cause death from agranulocytosis or Stevens-Johnson syndrome. Mifloquine is useful in areas of multiple drugs resistant. Thank you very much.